So hello everyone, and warm welcome to everybody from the studio of the last Sip of Science lecture in 2024. And our precious guest today is Professor Frank Brunkhorst, a good friend of mine from Jena University, Germany. And we've been working together with Frank more than 10 years. He's been a great supporter of the SEPS East initiative. So, Frank, thank you very much for accepting our invitation. And I hand it over to you, and we are really looking forward to your lectures on the outcomes after critical illness, a very hot topic. So over to you, Frank.
Thank you very much, Jolt. Actually, we are knowing each other for more than 20 years, I think. So old friendship with Hungary, old friendship with Budapest, and all the colleagues from SEPS East. So my topic will be outcomes after critical illness. I want to talk about clinical trials. I will talk about the position of the patients and the relatives who survived critical illness and especially sepsis. So, sorry, can you see the next slide? Actually, not.
Not yet. Yes.
Yes. Okay. So yeah, my conflicts of interest. So I'm involved in international clinical trials within the REMAP-CAP consortium in community-acquired pneumonia, and I'm Chief Executive Officer of the German Sepsis Society, but also Deputy Chairman of the world's only patient group called the German Sepsis Aid. And from the perspective of the patients, as I told you, I will give my lecture now. So I will talk about, my topics are sepsis, as you know, and I will talk a bit about COVID-associated sepsis and other sepsis cases. And during the pandemic, we treated in our intensive care units lots of patients with COVID-19 induced organ failure. But per definition, this is sepsis because infection plus organ dysfunction is defined as sepsis. So I will talk about these patients who survived critical illness. The principal difference between COVID-19 associated sepsis and other sepsis cases is that we know the definite pathogen in COVID-19 pneumonia very well. It's SARS coronavirus. But in the case of sepsis, so we have 100 different pathogens which can induce sepsis. And site of infection in COVID-19 pneumonia is normally the lungs. And we have multiple sites in other sepsis cases caused by bacteria, fungi, etc. Source of infection had been community acquired in COVID-19 sepsis and also nosocomial associated in other sepsis cases. Onset is very acute in COVID-19 and acute or subacute in other sepsis cases. So the pathogen detection, and this is very unique, and it was a new experience in SARS COVID-19 associated sepsis, is nearly 100% perfect, but in other sepsis cases. So we miss the definite pathogen which may induce sepsis in up to 40%. So we have organ dysfunction at multiple sites in bacterial or fungal sepsis, and we have the most common organ dysfunction had been RDS in COVID-19. So, and we have very good treatments available nowadays in COVID-19. So we have, as you know, steroids, and we have IL-2 receptor antagonists, but we have in other sepsis cases no definite working available adjunctive treatment until now. So I will talk about first survival. And so we have to make a difference between short-term and long-term survival. As intensivists, we normally look only for the short-term survival in our ICU or in hospital. In clinical trials, we use 28-day outcome, 90-day outcome, and so on. And this is a long-term assessment of sepsis patients from my university in Jena. So we have 3 or 4 different ICUs, internal medicine, neurological, and operative ICUs. And we followed up for more than 4 years every sepsis patient from the beginning on. So it was a prospective registry. It was not done from hospital discharge records retrospectively, but prospectively. So we had at all 1,975 patients under assessment, and the mortality rate was in the ICU 34%. So in hospital, mortality was 45%. And it's 6 months, and this is at the point which I would like to make. The mortality rate nearly doubled from the ICU mortality on to 59%. And we were also able to assess mortality after 48 months. And again, now mortality rose to 74%. So we have still very, very high mortality aside from ICU mortality. And there is no difference between men and women regarding survival rate, as you see here. We have, and this is well known from the literature, that now the older patients, here the blue line, 74 to 94 years old, they have a lower survival rate compared to the green line. The younger patients, 19 to 62 years and old, and this is also true, this association, the higher the initial Apache 2 scores are, the lower the mortality, the survival rate is until 48 months. So message is we have a rising mortality after hospital discharge. We intensivists are just looking for our treatment effects in the ICU or in hospital, and we are happy that our patients survive. However, when the patients are discharged, so they are still at high risk of dying. So, do our patients die with or of sepsis? I mean, we know from old times. So William Osler was saying that pneumonia is the old man's friend. And in the slides before, you saw that, in old people, in old sepsis patients, more than 80 years mortality is nearly 80%. So, and in many cases, we are not going for full therapy. We will not admit all very old patients to ICU, but reality is, especially if patients are operated by ambitious surgeons, so they are operated at 80 years old and more, and so then when complications develop, then we will also treat the patients on ICUs with a high mortality rate. What is the potential for sepsis prevention? This is a US-American retrospective analysis of 6 hospitals. And so intensivists and infectious disease experts were reviewing the medical records of 300 sepsis cases. Mortality was 34%. And most of the underlying causes of death were related to severe chronic comorbidities. And so giving an answer to this, do the patients die of sepsis or with sepsis? They very often die with sepsis because, they're dying of the underlying chronic comorbidities. And interestingly, in this trial from Boston, they only 3.7% of sepsis-associated death were just definitely or moderately preventable. So we have a high degree of patients where death is not preventable. So by preventive measures, a better treatment in the beginning, a better earlier detection in the beginning. So we have a potential of 12% of patients where death might be moderately or possibly preventable. So this is a new term for intensivists. It's called survivorship. It's not survival rate. So patients and doctors often see different views of a disease. It's not only in intensive care or sepsis. While the intensivists focus their efforts on survival, and this is clearly their principal and primary work, the health-related quality of life is in the focus of the patients. So from their point of view, the period after a sepsis diagnosis or after acute care in hospital is, in analogy to patients with cancer, described as survivorship. So survivorship is a very common term in oncology, and patients are organizing themselves in oncology and self-help groups, making the point that the quality of life after surviving cancer is for them of major interest. And I experienced, we'll go through this in short term, I experienced during the last 20 years that the surviving patients, the quality of life is of major interest. So this is a typical patient in our ICU, peritonitis, an old lady, 79 years old, day 1 septic shock, as you know, volume overload, high doses of vasopressors, day 8, septic shock resolved, and the fluid balance is getting negative. And this seems a success, but if you see at day 28, we see that we are not able to wean the patients successfully from the ventilator. So, and this is a slide I produced 20 years ago when I started my interest in long-term outcome and survivorship. And this is adapted to a slide, a figure Derek Angus published. So we are not that good in preventing sepsis or in early diagnosis, which is the case of the community or the emergency units. So when sepsis severity starts here in the community or in the hospital or in the emergency department, and then, if the severity is increasing, so organ dysfunction develops, Apache 2 scores are getting high, then the patient is transferred to the ICU, acute care. And we are quite good in treating organ dysfunction. We are not perfect, but in treating organ dysfunction regarding ventilatory, pulmonary dysfunction, cardiovascular dysfunction, and so we are quite good, but we have no definite treatment the dysfunction of the immune system, which is, according to my view, the major challenge for the next years. So we are treating the patients, and organ dysfunction is decreasing. Then we are quite happy as intensivists. We are transferring the patients either to the ward or to another hospital. They are out of acute organ dysfunction, but they still have compromised organs. The kidney is not working, so they still need some oxygen and so on. And then the interesting point is what to do with the patient. So if the patient is still in hospital, so in-hospital stay is an expensive thing. So the patients are transferred to the primary hospital where they coming from, where the patient is living, or if the patient are transferred into the rehabilitation facility. But there is still a severity of organs going on, existing. And this is primarily the muscles and the nerves, the terms critical illness polyneuropathy or myopathy. We have traumatic stress disorders, neurocognitive dysfunction, renal failure, and we have wasting syndrome. So, and one of my patients said when he was coming back to the ICU some months later, I survived, and that is the main thing. And I'm so grateful to God that I survived, and I'm off all of oxygen and consider myself all well, except I can't remember to take my medications anymore. So, in lots of counseling interviews I performed during the recent 15 to 18 years with patients, so they are calling me via a hotline in Germany, 10 hours, 10 hours over the day. So one of them said, I'm panicking about driving my car, but my doctor says now you have survived sepsis, so there are worse things. And young IT experts said, I can no longer focus on the screen anymore. So this is also true for young patients who are active in their profession. Or I have to make a shopping list I never used to. Another said, I lost 20 kilos during intensive care. My doctor says, oh, don't mind. You was overweight before. Or my handwriting has become small. My husband says, I should just use the computer. I'm constantly tired. My doctor says I should do exercises. And my kidney values are now twofold above normal 1 year after surviving sepsis. But my doctor says not bad, not that bad at my age. So there is misunderstanding. You cannot imagine when the patient is discharged from the ICU into the community. And so it's not that long ago. It's 12 years ago. 12 years ago that an expert panel were met together in the United States. It's stakeholders conference, and they invented the term post-intensive care syndrome, PICS, for all the long-term sequelae patients who survived critical illness, and especially sepsis, will develop. And interestingly, this is not only true for the patients themselves, this survivor PICS syndrome, but also for the families which are affected in a different manner as well. So the family are suffering mental health problems, anxiety, post-traumatic stress disorder, depression, and so on. And the survivors, the principal big long-term sequelae symptoms are mental health, cognitive impairment, and physical impairment, especially neuromuscular problems. So the reasons are not quite good understood so far. So there are some predisposing factors. We speculate whether the degree and the type of sedation is responsible for the sequelae, this neurological sequelae. Hypotension, hypoxia, glucose dysregulation, very important and underestimated metabolic dysregulation. And what is also clear that the amount of delirium patients develop during the ICU stay is associated with cognitive dysfunction in the following. And our friend Manu Shankar concluded recently that for investigators designing intervention to prevent or treat these long-term sequelae, a fundamental understanding of the clinical and biological mechanism in sepsis survivors is required. And we are by far away from any idea how these neurobiological problems develop. What are the reasons? What are the molecular causes of this disease? And this is clearly a task for the future decades to understand, to get more insights into the long-term sequelae in survivors of critical illness. And we are just at the beginning so far, so we have no clear pharmaceutical agents available to treat these long-term sequelae so far. So the outcome of PICS COVID means severe COVID PICS because of severe COVID in patients who had been mechanically ventilated because of ARDS are the same as in PICS survivors due to PICS sepsis survivors due to other causes. This is a nice cohort study from Australia. So it becomes clear that mortality is nearly the same in the severe COVID and in septic shock patients in this case, and the deterioration in clinical outcomes regarding new disabilities at 6 months are also the same. So in about 62% of severe COVID patients develop long-term sequelae, especially neurocognitive sequelae, and in 66% sepsis patients of other causes. So what are the most frequent long-term morbidities? The most frequent, the big ones, only the big ones. So this is in German, and do not mind, this is an original discharge letter from our hospital in a young female patient, 43 years, suffering streptococci sepsis with toxic shock syndrome, developed ARDS, received ECMO, multiple amputations necessary, 2 months at our ICU. So this is a long wording here for the house doctor who will see the patient after discharge and after rehab. And I will not go through all of it, but you see, it's a lot of wording and it's a lot of things. But this is the past. What is happening with the patient at the time of discharge? There is no word about what will definitely happen when the patient is at home. All the problems. So the first point is wasting syndrome, which as a result will lead to compromised physical and neurocognitive recovery. And one of the cornerstones of wasting syndrome in the critical is the pronounced protein loss due to increased protein degradation and reduced protein synthesis, resulting in muscle breakdown, and also reduced biosynthesis of hormones. And this is very important, and other messenger substances that I will show you in the next slide. Further, the esterification instead of the oxidation of free fatty acids will lead to fat storage formation in parenchymatous organs, which has first been shown by Great Vandenberge in the late 90s. And of course, hyperglycemia and insulin resistance is very, very common in critical, especially in protracted critically ill patients, as well as uremia. So this is important, and we have no idea how to treat this in the ICU. So you know that years ago, it's nearly also 20 now, it's 15 years ago, when, hyperglycemia was treated with large amounts of insulin in the hope that glucose will better transported into the cells in stress hyperglycemia. However, this concept did not work, as you all know. Intensive insulin therapy was finally not successful, but harmful in these patients. And this is a very interesting, very new, just some weeks ago, this was online, publication from a group of intensivists in Essen, Germany. And what they did in a small randomized controlled trial, they treated sepsis patients in the ICU with a ketogenic diet. So ketogenic diet means these patients received a very, very low amount of carbohydrates. So it was only 0.6 gram per 100 milliliter enteral nutrition. And the standard diet was the patients received 17 gram of carbohydrates per 100 milliliter. So this is the standard. And as you see here, the caloric intake was the same, but the ketone bodies were much lower in the standard nutrition group. They were much higher in the standard nutrition group, as you see here. And interestingly, also the glucose levels were lower. In the blue line, in the blue boxes are the ketogenic diet group. And as you see here, these patients treated with a ketogenic diet needed nearly very small amounts of insulin, additional insulin, to control the blood sugar, high blood sugar. And this was going on associated with significantly less days of days on the ventilator, days with vasopressors, less days with renal support therapy, and fewer ICU days. So it's just the beginning, and there was published another paper in Nature some month before. So this is a new point. Just put the focus on metabolic dysfunction in the critically ill, and we are not quite good in this, I think. And this is a topic of research and further tries in the future. And this is an old point here. Great Vandenberge published in in the end of the 90s. So we all know that the neuroendocrine system is dramatically changing during critical illness. As you see here, these lines here are the normal daily fluctuations of growth hormone or TSH or prolactin. You see here the gray lines, and you see here the acute phase of critical illness. There are still some elevation of growth hormone or the other hormones, but the daily, biological fluctuation over the day is changing. And in protracted critical illness, which is very common in our sepsis patients who are treated for at least 7 days in the ICU, there is nearly no production or there are no levels fluctuating in the bloodstream anymore. And this is a very important thing. We are not aware of any solution how to treat this. I know that the group in Leuven are treating some patients with growth hormone. They are quite good in treating neuroendocrine disorders. But it's a tricky thing. And I mean, this is only to make the point. And this is also true after the patients are discharged to another ward or to the rehab facilities, that these patients have this derangement of hormones in their blood. So another point is long-term cognitive impairment, which is one of the major. More than 60% of patients will develop long-term cognitive impairment points here. And the duration of ICU delirium is the most potent risk factor for development of global dysfunction. And this is an interesting study done by the same group of Boston I showed before. And this is data from the New Veterans Administration hospitals. So these are US military professionals and their relatives who are treated in these hospitals and ambulances, and they get neurocognitive test batteries every year, which is part of the offer the Veteran Hospital Administration is giving to the military personnel and their relatives. And so it was possible to assess for cognitive dysfunction 3 years before patients develop sepsis, or 1.1 year before development of sepsis. So, and here are they received cognitive testing, so psychological and cognitive test batteries. So they had minor limitations or moderate limitations before sepsis. The red bars are moderate to severe limitations in 5%, up to more than 5% 1 year before. And after sepsis, so in the case the patients developed sepsis, it was a large cohort of 10,000 of patients. So they can identify patients who develop sepsis and who are treated on the ICU. You see that there is a dramatic increase within 9 months of cognitive dysfunction after surviving sepsis. And this is still going on after 2.8 years. So it's a long-going, long-lasting, continuous process due to sepsis or treatment in the intensive care unit. So this is clearly the case. And the point is that this is brain injury. And this brain injury, in contrast to dementia, has first acute onset, so the patients do not have that much cognitive disorders before. It has the potential, this acute brain injury, for improvement. not to baseline levels, but might improve. And in case you will treat it. So it's potentially amenable to rehabilitation, where dementia, we have no clear treatment for dementia so far. So it's important to make a diagnosis of cognitive impairment in patients after surviving critical illness. This is my point, what I wanted to say. I was interested in the development of post-traumatic stress disorder, and did with psychologists a lot of studies in surviving patients. And we found out that post-traumatic stress disorder is a very, very common in 70% patients, if tested psychologically after discharged from the ICU, develop post-traumatic stress disorder. And so, which is characterized as avoidance of activities and situations which may evoke memories related to trauma and related to the ICU. This is vegetative overexcitement, increase of vigilance, dreadfulness, insomnia, outbursts of fear, panic, or aggression. Point is that all these patients are not able to go back to their profession anymore. First, after discharge, they don't know that they have it, because it's not part of the cognitive testing or psychological testing in the acute hospital. The point is that not only the patients develop PTSD, but also the relatives are involved. So this is part of the PICS family concept. Another point is critical illness polyneuropathy and myopathy. So these are potentially modifiable risk factors. Hyperglycemia, treatment with glucocorticosteroids, neuromuscular blockers, immobility, and non-modifiable risk factors. And which is, can be tested accurately by electrophysiological examinations. And if you do this, if you really do this, and we did it in our ICU very often, then you see that already 3 days after sepsis onset, you will detect alterations by electrophysiological examinations. And this is also, it's very often, and the characteristic clinical appearance is this muscle loss, this muscle weakness in these patients, as you may all know. This is a former patient in our ICU who survived this, a young patient, a marathon runner before, and his wife was pregnant just before he developed pneumonia. Was due to Streptococcus pneumonia. And this is an interesting study by Stefan Weber-Carstens from Charité Berlin, published in the Blue Journal 10 years ago, but still no one is now proceeding this kind of research. What they were doing in patients with RLS, they stimulated the patients with electrical muscle stimulation, which you may know is quite common in the gym. Yeah, it's very cheap. So they stimulated one leg, but not the other leg, and then they performed muscle biopsies and looked whether there is an effect of electrical muscle stimulation on type 2 fiber atrophy, and they could demonstrate that there is an effect. So mobility and contraction, if you perform this in the patients, might be helpful and might avoid a type 2 fiber muscle atrophy. Another long-term sequelae, which is not well known to most of intensivists, is secondary sclerosing cholangitis. which has been described now also in patients with RDS, who survived COVID-19 patients. So it's a strange disease which occurs after discharge from the ICU, sometimes weeks after discharge. It's an ischemic of, obviously, we don't know, injury of the biliary tree. And the consequence is that biliary casts are formed in the biliary infection. This is not treatable. It's not treatable. So, it will definitely end in liver cirrhosis. In the consequence in young people in Charité Berlin, we had more than 50 patients who had been young patients after critical illness, not only sepsis, but also polytrauma and long-term ICU stay, who received liver transplant. So it's big thing, all these long-term sequelae. This is not that common, secondary sclerosis and cholangitis, but it's also now a new term in sepsis survivorship. So who cares about sepsis after patients are discharged from the ICU? In Germany, we have about 94,000 sepsis survivors each year. We have 48,000 GPs in Germany. So it's just an estimate. So there are only 1 to 2 sepsis survivors per GP per year. So the learning curve in GPs is very, very low. They will not treat sepsis patients, former sepsis patients, that much in their ambulance. So knowledge about PICS sepsis is still little known. We have also a problem because we have no specific rehabilitation facilities, and we have few studies on outpatient care. So the problem is that we have no adequate diagnosis at the time of hospital discharge. And we tried it in our ICU to test the patient with cognitive batteries, psychological batteries, but they are not able because they are so compromised at the time of discharge. So they are not receptive to these complex tests. And the other point is that the neurologists do not perform EMGs or EMG at the time of hospital discharge. They are not carried out. So we have no diagnosis. And even after hospital discharge, patients usually do not receive diagnostics because their GPs who provide the follow-up treatment have not the necessary knowledge. And these are because, at least in Germany, but also in other European countries, maybe in Hungary too, there is no disease without ICD coding. No? And if at in the discharge records, the long-term sequelae are not mentioned as the U51 code for impairment of cognitive dysfunction or the other long-term sequelae, the disease is not existent for the system, for the healthcare system. This is the major problem. And what we are now doing in German ICUs, we try to add a text block in the discharge records. So just, for the follow-up doctors, there is a high risk of following disease occurring in the post-discharge course. And because we have no diagnosis, we cannot make a diagnosis at hospital discharge. And so it's kind of to make the people, the treating doctors after discharge, kind of alert for the potential long-term effects of critical illness. So I'm coming to the end. In 2005, I founded a self-help group called German Sepsis 8, which is now a patient organization with more than 300 members all over Germany, but also in Switzerland and in Austria, some patients. And so what we are doing, we are giving support by by phone, by hotline, 10 hours a day, so to the relatives, also the patients, or by email or letters. And we are receiving every day in about 10 to 15 telephone calls. And we have trained former sepsis survivors who know all the symptoms, and who are able to give the survivors some support in case of acute care problems when the patient is still in ICU. So the physicians can call me, and so I can give some advice to the intensivists who are treating these patients. So to be done, finally, what's to be done? This is a summary from an excellent review I recommend from Margot Harridge and Ellie Arzelai from the New England Journal just last year. You should read this article about chronic critical illness. So what is our to-do list? Intensive care units focus on pain, agitation, and delirium development and treatment. And to be honest, we are not doing this enough. We have to inform the GPs about upcoming problems which will come. We have to assess long-term outcomes, at least 1 year. We have to also assess if you're performing very expensive, extensive, invasive procedures, for instance, ECMO, we should assess ICU and long-term outcomes in these patients. We have also to establish time limits for treatment in the ICU, weekly determination of therapy goals, shortening long-term stay. And this is what I have showed you, this call for better research by prioritization of basic and translational research on organ failure with regard to the long-term consequences. Another point is transsexual care. I won't go to all of it. Communication with the relatives is very important too. Finally, there are some ideas about this. This what was developed by Wes Alley from the United States, this ABCDEF bundle, assess, prevent, and manage pain, spontaneous breathless, awakening tries and breathing tries, develop, think about the choice of analgesia and sedation therapy, assess for delirium, and very important, early mobility and exercise, and family empowerment and engagement. And with this, it was a not randomized controlled study. It was a quality improvement program in more than 50,000 adults in the United States, published some years ago, 5 years ago. So it was not a prospective trial. It was a quality before and after trial. They were able to show that some elements of the interventions led to a better outcome in terms of ICU discharge, even death. We do not know. It's just a good idea to perform this. A first step has been done. This is in the 70s, where in the United States, the patients were mobilized early. I mean, this was in the 70s, back in first patients were mechanically ventilated. And there is a step now into more of these early mobilization strategies in the very ambitious intensivists who are doing this. There is also a university in Czechia, in Poland, who are doing this. But, it's time-consuming, nurse-consuming, as you know, but it is working. So this is my last slide. Thank you for your attention. These are postcards we produced for ICU survivors and their relatives and we are distributing it for patients and relatives and as the German Sepsis Aid Group. Thank you.
Well, thank you, Frank, for this comprehensive summary of basically covering all of the potential unfavorable outcomes of our patients and giving some instruction on how to, or some ideas how to improve. And first of all, congratulations. I mean, your unbelievable achievement, thinking about the World Sepsis Day, which was again initiated from the Jena group, and the sepsis update conferences you've been doing for decades, biannually, and now the Sepsis Health Fair. This is something new. I never heard about it. So really congratulations for your devotion. And it gives us, in the meantime, we were talking in the studio, and it gives us a lot of to-dos as well. So thanks again. Well, I don't know, did we have any questions? Not yet on the chat. Any questions from you guys? Is that, yeah, okay, let's see. Oh, you have a microphone.
My question is, how do you explain, Professor, that the mortality of the patients, their SOFA score was between 5 to 20 maybe, and it was around 50%. It's a huge mortality rate. How do you explain this? Is
this was the Apache
along your
score.
along your own data in the
Apache 2 score.
Apaches, yeah.
I think in the patients with 5 to 15 points, it was in about 20% or so. No, it was lower. So maybe it was too fast to show the slides. So in patients more than 25 points at onset, so the mortality wasn't about 34 to 40%, and just about more than 25 points, now it's about more than 50, 60% mortality. This is quite in accordance to the literature. It's nothing new. But the point is that this effect is still detectable after 48 months.
One of your slides, there was a Kaplan-Meier curve. I can't remember which study that one was. It was the New Zealand. It was the ANZIX study and the mortality went up to 180 days. The follow-up, 180 days. But when you look at the Kaplan-Meier curve, actually the overall mortality was completed, in inverted commas, by day 30. And after day 30, the Kaplan-Meier curve was more or less flat. So that is a bit of an argument with you saying how important this is to follow up for 2 years, because the mortality occurred within the first 2 months anyway, or within the first 1.5 months. So, I mean, if you do a 10-year follow-up, then everybody will die almost, So
yes.
So we are. I don't think that we are making a big mistake in really observing, first of all, the so-called short-term mortality. Do you still disagree with that?
Yes, I would say so. A compromise will be 180 day mortality would be better than 28 day. In the Australian study, actually, the curve was so flat. It was not decreasing anymore because they lost a lot of patients for follow up. Yeah,
all right.
So there were very few patients there. What we did in our study, we contacted the GPs. So, and we got the outcome of the patients from the GPs. So we were able to make for this 1,700 patients and more than 70% a good follow-up. And this was working in a small state like Thuringia now. Not more inhabitants than in Budapest, I think, or a bit more.
Yeah. And on one of your first slides, when you show the difference between COVID-19 and sepsis, you had the pathogen is 100% sure in the COVID patients, but only around 60% in the sepsis cohort, right?
Yes.
You remember that table. Now, that made me think that 60% means that in 60% of cases are actually the pathogen identified, or this means that we include, we call patients septic, who are not septic, but they have hyperinflammation due to other non-inflammatory injuries. And that leads to my comment that although you were talking about post-sepsis, but it is basically post-critically ill outcomes. Is that, what I mean?
Absolutely. This is why I actually, this is a slide which I did by myself. Yeah. We all know that, we cannot detect a pathogen in all patients, sepsis patients. We have a high number, about 1/3, where sepsis is only suspected. And it's also not quite clear whether there is a clear site of infection. No? So, and this makes me, same as you now, think about, probably we are not treating sepsis patients there. So now we're treating something different.
Of course not. I have never treated sepsis in my entire life. You know that. But I treated patients with organ dysfunction and infection, hundreds of times. So yeah. Well, anyway, any further questions? Well, if not, I would really thank all those joining us online. And this is the lecture is recorded and the discussion, and this will be available in a couple of days, thanks to Attila from the Center of Translational Medicine. And I would also like to thank the Semmelweis University for hosting this event and supporting it. And most of all, I am really grateful, Frank, for taking your time and giving us this very nice lecture and spending some time with us. And I hope to see you in the new year. So Merry Christmas, Happy New Year, everybody. And the SIP of Science series will reconvene in 2025. So all the best. Bye now. Bye-bye.
Thank you, Joel. Thank you all. Thank you.
Bye-bye.